On behalf of CME Outfitters, I'd like to welcome and thank you for joining us for this CMEO briefcase titled Managing HIV in an Aging Population. Today's case is focused on some of the challenges related to medical comorbidities that you may see in your practice as your patients with HIV age. I'm David Wohl. I'm a professor of medicine. I'm a site leader of the Global HIV Prevention and Treatment Research Site here at the University of North Carolina. I co-direct the Viral Hemorrhagic Fever Clinical Research Group. And the goal for today's activity is to provide you with the evidence and strategies to help you individualize treatment regimens for aging patients with HIV infection based on their specific needs and their comorbidities. So when we think about people living with HIV and we think about them getting older, it's hard not to look at some of the data that we have indicating that many of our patients are getting older and living with HIV. It's been estimated for quite some time that more than half of the people who are diagnosed with HIV and living with HIV in our country are over 50 years of age. I think soon you'll be seeing slides like this where we're talking about the proportion of people who are over 60. The number of people who are living with HIV who are over 50 years of age is projected to increase by about 23% by 2025. So more and more, we're going to be dealing with folks who have not only HIV as a medical condition that we have to deal with, but all the medical conditions that are part and parcel of living a longer life. Certainly, we know that people living with HIV have comorbidities and maybe more comorbidities than people living without HIV for a variety of different reasons. We know that this can include cardiovascular disease, bone loss and frailty, renal impairment, and also obesity, which is interesting because earlier in the epidemic, we were worried about people losing weight and wasting syndrome. And now, like most of the rest of the country, obesity and being overweight is a challenge for many people living with HIV. So we know that there is a whole host of these different comorbidities, including those not listed here that we'll talk about, that really do serve as a double strike for people living with the virus. And why they have these comorbidities is a complicated question. And we know that there's some chronic immune activation and inflammation that occurs during chronic HIV infection, even in people whose viral loads are suppressed. We also know that many of our people who are living with the virus have risk factors for comorbid conditions, whether it be smoking or sedentary lifestyles, steroid use. So there's a bunch of different reasons that related to HIV and outside of HIV. As we'll talk about, HIV medicines as well may also play a role in some of the comorbidities that we're seeing and that we're worried about. So let's take a case, for example. So this is a case of Stan. He's 65 years old and he has a history of injection drug use, but he no longer injects for over a decade. He's been also HIV infected for quite some time and has over a dozen-year history of treatment for HIV. He's been treated for hepatitis C in the past successfully. He did have a heart attack not long ago at age 61 and required angioplasty. He's moderately overweight just on the border of being obese. He leads a very sedentary lifestyle. And partly we see this vicious cycle where he can't exercise that much because he has some mild to moderate osteoarthritis, especially in his lower extremities, his knees and his hips. And so when we want him to exercise, he complains about pain. When we look at Stan's medications, he's on metoprolol XL. He does take naproxen, 375 milligrams twice a day, and this is reduced from a higher dose that he was on before, but that he really needs to function, he says. And interestingly, he's on a combination of HIV medicines that he's been on for a while that he's very, very adherent to in a number of different ways. He takes his medication every day, but he also really finds that this medication has saved his life and is well tolerated, and he's been reluctant to change. So he's on atazanavir and cobicistat, along with tenofovir diprodoxyl fumarate and emtricitabine, and he's been on those medications for quite some time. So I was able to do a virtual visit with Stan. So let's listen in to the encounter that I had with him to talk about some of these issues. Hi, Stan. Good to see you again. Haven't seen you in about 6 months. How are you doing in these crazy times?
I'm hanging in there, Doc.
Thanks for going to the lab and getting your blood drawn before the appointment. With virtual visits, it definitely makes things a little challenging. but we're trying to make it work. Anything new you want to bring up before we get started?
Well, I had a few things come up since I was in here last. I had a heart attack a few years ago and I've been on meds, but I did have to have an angioplasty about 2 months ago. I had been feeling pretty punk, no energy, just not feeling great. I thought coming out of the procedure I'd bounce back, but it hasn't seemed to happen.
Okay, let's talk a little bit more about that. Let's start with energy. Is it a lack of energy in general, or when you exercise? Do you exercise?
I'd call it a lack of energy overall. Angie's always pestering me to get out walking, but I'm just not feeling the same. Heck, I can barely make it around the block before I want to go back home. She's pretty strict with me from a diet perspective. Won't even let me have a beer, although I have to say I sneak one every now and then. Not often, don't worry.
What about drug use? Anything I need to know about?
No, I'm not going to tell you I don't smoke pot every now and then, but I'm clean from injection drug use 13 years now.
Great, that's fantastic. As individuals get older, we slow down some, but you're really not that old. HIV itself can impact people as they age and even reduce their energy. Different ages of frailty.
Frailty? What the heck? What am I, a little old lady?
It's just a term, it's a medical term. It affects men and women. There are different stages of frailty over a spectrum that we need to pay attention to in people with HIV. It can be associated with even mortality. It's important that we recognize it early in the early stages because science tells us that we could prevent the progression. So I don't want to slough it off.
Okay, makes sense, I guess. So what do we need to do to head it off at the pass?
Well, first off, I want to think about your medications to make sure they aren't contributing to the problem. Second, weight loss is a simple thing that could be done that makes an impact. Start listening to Angie, but I'm also going to give you some information to help. Now let's talk a little bit more about your lab results and some ideas about your medications.
Whatever you say, Doc.
So what we heard from Stan was a few different things. One is he's got this low energy, he's more sedentary. That could be a signal for a lot of different things. Certainly we worry about his heart. We worry about depression. We worry, is he more isolated because of the pandemic? Like, what is going on? He definitely has less energy. Can't do a physical examination, but we did do some blood work and that may give us some clues. We want to make sure he's not anemic. So there's a whole host of things that are going on in our mind. I do worry that given that this has been going on for some time, this is not some occult GI bleed and he's anemic. I'm more worried that maybe over time he's becoming less and less energetic because he's becoming a little bit more frail. His muscle mass is decreasing, his energy levels are going down, his weight is going up. And so trying to turn a little bit of that around and tip the odds in his favor by maybe getting him out, going to swim if he can do it safely, trying to cut down, and we didn't talk about it in this visit, but I think in subsequent visits, on too much caloric intake, really trying to get him moving. And I think that would help his mental and physical status as well. And even introducing this concept of frailty, I think was a shock to him, but I think helps him understand where I'm coming from and some of the things that I don't want to happen as he goes down the road. He's thinking of frailty as being something associated with being a little old lady, and he doesn't want that to happen to him. And then lastly, thinking about what can I do as the prescriber of his medicines to make sure that I'm not contributing to some of these issues. And there may be things that we are doing that could set him up for trouble, including making his bones weaker, for instance, or drug interactions that might lead to problems with side effects to some of his other medications as he needs them. So I think there's a whole bunch of things that we can delve into here, but at least we're starting to scratch the surface with Stan during this initial part of the visit to understand where he's coming from and some of the things that we're gonna have to think about for this visit and subsequent visits. So when we think about physical functioning, which is really something that we focused a lot on in the beginning part of our discussion with Stan, there are risks for declines in physical functioning that we've already talked about, and these can accumulate. And then you get into this cycle where people become more sedentary, they become weaker, then you start to see things like falls and hospitalizations and even increased mortality. And there's been data that have looked at this, including recently, and there was a pretty interesting study where over 260 people living with HIV, physical function impairment and pre-frailty was present in almost 50%. 90% almost were physically inactive, so that's very, very common. 31% reported not being able to perform one or more instrumental activities of daily living. Of course, the comorbidities are there. Being overweight or obese was very, very prevalent. Hypertension, of course, was also prevalent. And older age, African-American, Black race, having HIV infection and being on ART for at least 10 years, greater BMI, higher waist circumference, hypertension, and physical inactivity were all risk factors for poor outcomes. We also know that bone health is really important to older people, both living with HIV and people without HIV, and the prevalence of frailty in HIV positive individuals who are even in their 40s and 50s ranges from 5 to 28%. Frailty is predictive of a number of adverse outcomes. The Veterans Aging Cohort Study has really plumbed this nicely, and frailty seems in this cohort to increase the 5-year risk of hospitalization substantially, and even mortality in people living with HIV. And earlier diagnosis and initiation of ART, reinforcement of adherence to therapy, can decrease the frequency of these risk factors. And HIV treatment decision-making is a factor that should impact our decisions about bone health and frailty, because bone health is integral to avoiding frailty. It just takes a fracture. It doesn't have to be a lower extremity fracture, even a fracture of an upper extremity bone or a vertebral fracture for sure can kick people down a pathway that leads to frailty and all these adverse outcomes. So it's important to pay attention to bone health. A lot of attention has been paid to cardiovascular risk in people living with HIV. And of course, cardiovascular disease is one of the leading causes of mortality in the world for people without HIV as well. But even in people who are HIV infected and virologically suppressed. And with an aging population, this is again, one of the major things that we have to think about, and that is a challenge, as people no longer die from pneumocystis pneumonia or cryptococcal meningitis. They are more apt to suffer from the things that the rest of us suffer from. And so cardiovascular disease is key. The factors driving the risk of cardiovascular disease in people living with HIV are complicated, and there's many different ones that may be related to the virus, may be related to therapy, and to the risk factors. Again, the Veterans Aging Cohort Study, or VAX, this is a huge cohort study, over 80,000 participants with HIV and without, in which HIV was associated with an increased risk of acute myocardial infarction, even after adjustment for traditional risk factors. And it's interesting, some of the data that we've seen from other cohorts indicate not all of these are atherosclerotic, and that maybe half of these are demand MIs, in such that you don't find much as in the way of plaque, but that there's a mismatch between supply and demand to the myocardium that could be due to a number of factors. Some of that may be sepsis, bacterial infections. It could also be substance use, especially with cocaine. So there's a lot going on that we completely don't understand about cardiovascular disease risk in people living with HIV. And it's not all the typical type 1 MI with atherosclerosis, blocking arteries, spasm of the arteries, and then myocardial infarction. Kidney disease is also really important to talk about when we talk about aging with HIV. People living with HIV have many-fold greater risk of end-stage renal disease in the general population, especially among African Americans and Blacks. Prevalence of chronic kidney disease in people with HIV is increasing over time, and it's often related to diabetes and hypertension, which are not related to HIV or HIV therapy. So this is just a risk factor that's more prevalent in people who are diagnosed and living with HIV. Long-term ART exposure definitely contributes to the burden of renal disease in some people, highlighting the need to really think about our therapies and what impact they're having on kidney function. So let's look at some of the guidelines. This is from the US Department of Health and Human Services guidelines and the treatment guidelines for older adults with HIV who have comorbidities. And so osteoporosis is a clinical scenario that's highlighted. And in general, what we have to do is avoid TDF. And remember, Stan is on TDF, and we don't have a DEXA scan from him, but that's something that I would be interested in looking at. Abacavir may be used as an alternative, but has its own issues. And you can see here, there's much in the way of caveats. TDF, as you know, has been associated with decreases in BMD more so than other drugs, and also with renal tubulopathy in some patients. And so we have to be a little bit thoughtful about that. Now, TAF is another alternative. It's a different way of delivering tenofovir to the cells where HIV resides. And so that, again, is another alternative that I think many are turning to instead of abacavir. What about other drugs? And there's a bunch of data that we can look at of some of the medications listed here that are all integrase inhibitors on the left. And whether we're talking about bictegravir, dolutegravir, elbictegravir, or raltegravir, it really has to do more with what the drug, the integrase, is companioned with. So again, when we see TAF along with bictegravir and FTC, we can see that there's great virologic suppression, just as we'd expect. But we don't see the kind of bone and renal issues that we'd seen with TDF containing regimens. And so for dolutegravir as well, and we've got great data on dolutegravir, and switching from TDF to dolutegravir with other drugs, including rilpivirine, we could see improvements. And the general theme here that you're going to see for all of these is that once TDF is removed from the picture, we see increases in bone density and improvements in renal markers. So what about cardiac risk? Considerations in the guidelines are to avoid abacavir because of its association with myocardial infarction over time. Lopinavir, ritonavir, and most of the boosted PIs have also been associated with cardiovascular disease, especially older protease inhibitors that were unboosted. Atazanavir is, interestingly enough, a drug that has not been associated with myocardial infarction in some of the cohorts, and darunavir also not really clearly associated with myocardial infarction in cohort studies. And again, what the contribution is unclear. Whether or not this is all driven by lipids or not. In the case of abacavir, there may be more direct effect, and many are investigating that. But for all the protease inhibitors, especially boosted protease inhibitors, we're seeing elevations in lipids that may explain some of that. And maybe with atazanavir, there's a counterbalance of hyperbilirubinemia that's protective. Hyperlipidemia is, of course, something we also have to pay attention to, given its relationship to cardiovascular risk. And most of the older drugs all have an impact in some way or another on lipid subsets. The newer drugs, less so. When we start looking at integrase inhibitors, really, these are more neutral to lipids. One thing that we think about with TDF is it lowers lipid subsets, including HDL as well as LDL. And when we switch people from TDF to other combinations or just remove it from the picture, what we often see is lipids increasing. And again, that's because of the suppressive effect of TDF, probably more so than any inherent increase in lipids due to the drugs that are now being used. So it's complicated. We don't know what these effects mean as far as cardiovascular risk, and really the cohort studies we've seen give us the best indication that there are some drugs that for one reason or another, whether they be lopinavir, ritonavir, or abacavir, or the older PIs that are associated with cardiovascular disease. Chronic kidney disease also are addressed by the guidelines. And again, it's TDF where we're implicating a direct role. We know that TDF can be nephrotoxic in some patients, especially those with underlying kidney disease. There's a host of drugs that could be used instead of TDF, more and more, including TAF. Again, abacavir, we have to be careful about given the other considerations we've talked about. And more, we're looking at nuke sparing or nuke light regimens that can be used, especially in this situation. One thing I'll mention, given Stan's circumstances, that atazanavir has also independently been associated with kidney disease, and it may be due in part to the crystallization of the drug in the kidney. And again, we're not using a lot of atazanavir now, but when we were, this was something that a lot of us were paying attention to. Much more recently, we've seen concerns about weight change as we start or switch HIV medicines. And there have been a number of different studies that now are looking at weight, given some of the data we're seeing from other parts of the world, where people who are treatment naive are starting different therapies and having vast differences in the amount of weight that they're gaining. The bottom line is we do see that there's greater weight gain when people are starting or switching to an integrase inhibitor, more so with dolutegravir and bictegravir than raltegravir or elvitegravir. There also does seem to be an effect of TDF on weight such that it seems to suppress weight gain. So that means that if you're starting a non-TDF regimen, such as with a TAF-based regimen, we are seeing increases in weight disproportionate to what we would see with TDF. So overall, what we're seeing is maybe this compound effect of a TDF sparing regimen that has TAF, let's say, plus an integrase leading to greater weight gains than we would see with a TDF integrase or a non-integrase, non-TDF regimen. So here, as you can see on the far right in the advanced study, the beautiful stepwise implications of starting on a regimen that has TAF and dolutegravir, an integrase inhibitor, a newer integrase inhibitor, the weight gain was much higher than if you started with dolutegravir and TDF versus efavirenz and TDF, where we saw much lower gains in weight, much more on the par of what we see when we start people on therapy in general. So this is an evolving story, and we have to really pay attention to it because there's independent data that show that as people gain weight, their risk for frailty increases. Again, having to do with mobility, osteoarthritis, joint problems, cardiovascular disease, etc. So let's go back to Stan and our virtual visit. So we don't want to make too many changes all at once, but I do want to change your HIV medication to one that would have less impact on your bones and kidneys. It doesn't appear that you're having any kidney problems, but your non-steroidals, your NSAIDs, can have a negative impact. Losing 10 pounds alone can make a big difference in your osteoarthritis and might even allow you to cut back on your NSAIDs or even stop it completely. I'd like to see you do some low impact exercise like swimming. It would be a very good option that could help.
I'm open to trying. I'm not a fan of taking any more medications than I have to. And if we can get these old knees not hurting by swimming, I'm open to it.
That's great. You know, we've been talking a lot about your physical health, but let's not take our eye off mental health. It's important, and it can also contribute to poor outcomes.
I know. Feeling down and defeated doesn't help anything. I know that in a day, it was a contributor to my drug use.
You know, since we're making a medication change, I'd like to see you again in about 6 weeks. Does that sound good?
It does. Thanks.
So at the end of this visit, we were able to focus a little bit more on some of the things that we could do to help Stan, and again, try to introduce to him, at least during this introductory visit, some of the things that we could do interventionally. So one thing I was thinking hard about was changing his medicines. In addition to the diet and the exercise that we can talk about, and outside of pandemic times, getting him in with a nutritionist, being able to work with him with probably some community-based organizations to see if there is a place where he can go to swim, those types of things. But we were able to talk more about his mental health as well, about how he's feeling, that he hasn't gone back to using drugs, which is great, and really trying to get him to take a positive outlook. And the medication change, we didn't go into it in detail in this snippet, but what I'd really do is try to get him off of the boosted protease inhibitor, get him off of the TDF, really stack the odds in his favor that we can get him on a simple regimen that wouldn't affect comorbid conditions like his bones or his kidneys or cardiovascular disease. We would have to be thoughtful about what we're going to switch to, because given what I said about weight, it's hard for him to lose weight if I give him a medicine that's going to increase his weight. So it's complicated, and we have to think more about these choices, especially as people have these comorbidities or these risks for comorbidities. So I think that's another really important part of it. And the reason we pay so much attention to this is frailty is really important in HIV. These are incredible data from this cohort in Baltimore that I really think tells us more about what it's like living with HIV compared to people without HIV, because the cohort is made up of people who are both HIV positive and HIV negative in Baltimore. And the HIV negative folks, like the HIV positive folks, are individuals who've had a history or current substance use issues, injection drug use particularly. And so there's more parity, I think, between the controls and the people living with HIV than we see in most other studies where we have both positive and negative people enrolled. And so I find them a little bit more easier to compare. And when you look at many of the outcomes in the controls, they're not great. again, because it's a challenged population, often with comorbidities. And so it's interesting when you look at this Kaplan-Meier curve, the best scenario, of course, is to be followed for years and not be frail. And that's what we see in blue at the top. But at the very bottom, you can see that people who are frail from the beginning and continue to be followed, their survival is much lower. And in between, we can see this transition that if you go from being frail to non-frail, which does happen, you can reverse frailty, you start to get back up towards the blue. It seems to attenuate the frailty that you had in the beginning. Whereas if you've gone from non-frail to frail, you start to look more like the red and more like people who are frail. So this is why we really have to pay attention to these elements, the things that we're seeing about mobility, being able to get out of a chair, being able to attend to your activities of daily living. Those are the types of things that we have to assess when we're looking at frailty. And people who are frail or pre-frail, we have to do what we can to get them to no longer be frail. And so we have a number of these different SMART goals, right? So these are specific, measurable, attainable, relevant, and timely. So raise clinical suspicion about comorbidities. We've done a great job of this in HIV. I think more and more when we look at the data, HIV providers are attending to cardiovascular disease. They're providing statins as is appropriate, lipid-lowering therapy in general. Bone health has really gotten a lot of attention, and while we may not be doing as many DEXA scans as we could or should, certainly we're paying attention to it and getting people off of drugs that can contribute to their bone density being reduced. Kidney disease, we monitor this very easily with many of our blood tests, so that's great, and we're paying attention to that. And again, I think we've made some strides in avoiding nephrotoxic drugs, and paying attention to NSAIDs, I think, is also important. We didn't talk about it, but neurologic disorders and thinking disorders, a lot of our patients have a lot of risk factors for that, whether it be depression, closed head injuries, other things that I think make cognition a major issue for people in general, but also for people living with HIV. And then there's the whole, pull the levers that you can. HIV therapies can contribute to some of these things. I think we should stack the odds in people's favor, as I keep saying, and really try to use therapies that reduce the risk of some of these things happening. And if it does start to lead to something you don't like, lipids start to go up or weight goes up, we might be able to switch medications to try to alter the trajectory and again, try to accommodate the health of these people and support the health of people who might be at risk for some of these things. So we didn't talk about it, but I think another major part of this as well is mental health. And Stan multiple times sent signals to us that his mental health was at challenge as well. And I think a subsequent visit where we talked more about that, more about why he's isolated, why he's at home, especially during challenging times, during lockdown and when we're social distancing, I think that's really important. There are other data, again, from the veterans group and others that show that depression is so prevalent and also associated with many of the same outcomes that we're talking about, whether it be myocardial infarction or hospitalization or mortality. Also contributing to that, fortunately, people living with HIV are more likely to be living in poverty. They're more likely to be discriminated against and stigmatized, either due to their sexual orientation, their history of substance use, incarceration, race, ethnicity, sexuality, gender identification. So there's a lot stacked against our patients. And I think that also has to be recognized because that has incredible impacts on their health. And there's many data that show that people who are living under those challenging circumstances, people who've had challenges even back to childhood, have poor health outcomes. And I think that's something that we haven't really delved into enough in our folks living with HIV, but probably underlies many of those issues that we saw in that pyramid really do trace back to some of those more fundamental living a tough life risk that I think contributes to some of those outcomes and that are harder to deal with. There's no magic pill to make you have a happy childhood or to negate the traumas and the stresses of living sometimes under adverse circumstances. So with that, thank you for your attention. And here's information of how you can receive credit for this activity.